Hi, my name is Jennifer Yu. I'm one of the internal medicine residents here at the Mayo Clinic. I'll be talking about our article, Arthrocentesis and Joint Injections in Patients Receiving Direct Oral Anticoagulants, which will be featured in the Mayo Clinic Proceedings. One of the common complications that we worry about is bleeding with these procedures, although they are very safe and well-tolerated procedures. This is a particular concern in patients who are taking anticoagulation. Now, there are guidelines in existence for patients who are anticoagulated with warfarin, and we found that in studies that the rates of bleeding in patients anticoagulated with warfarin is quite low, and that has been approximated at 0.2% in the literature, or 1 in 500 procedures. So the current guidelines suggest that warfarin with a therapeutic INR goal of 2 to 3 can be safely continued while a patient undergoes a joint aspiration or injection. However, there's no such data for the population of patients who are anticoagulated with these direct oral anticoagulants. And what we find is that clinical practice varies quite widely. Some practitioners may be comfortable continuing anticoagulation through the procedures, and other practitioners may prefer to hold the anticoagulation and then proceed with the procedure once the anticoagulation is no longer active in the patient's body. But obviously there are risks associated with that, primarily delaying the procedure, and a risk of either venous thromboembolism or stroke if the patient is not on their anticoagulation. Recently, we've had updates to the guidelines in 2016 where these direct oral anticoagulants, including the direct thrombin inhibitor dabigatran and the factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban, have been now added to first-line therapy for anticoagulation for venous thromboembolism and for the prevention of stroke in patients with atrial fibrillation. So we find that the population of patients who are receiving these medications and also needing joint injections and aspirations is increasing. So what we did was we looked at adult patients who had joint injections and aspirations in the outpatient setting here at the Mayo Clinic in Rochester. We began back in 2010 when dabigatran was introduced as the first oral anticoagulant, direct oral anticoagulant, through 2016. And we captured 1,050 consecutive procedures in 483 patients. And so we looked at their baseline characteristics. The average age was about 75. It was fairly evenly split between males and females. We obtained their basic lab values and some of the clinical demographics. There were very few patients who had any renal or hepatic dysfunction, and about 20% of the patients were concomitantly taking aspirin, and only about 1% who were also taking clopidogrel. The majority of procedures were arthrocentesis and joint injections for the knee, which comprised about 40% of procedures. Subsequent groups were also shoulders, hips, hip bursas, hands and wrists were the other largest groups, and then fewer patients for feet, ankles, and other joints. And in looking at the patients and procedures, we did our best based on the information available in the chart to ensure that the patients were taking the direct oral anticoagulant. It hadn't been held for any length of time prior to the procedure. And then we looked post-procedurally for any clinic visits, hospitalizations or emergency department visits for follow-up to see if there was any mention of any bleeding complications that would require medical attention. And in all of those procedures, 1,050 procedures, we did not find any evidence of bleeding events. In looking at the data, we were also able to make some interesting observations about prescribing practices. We note that in 2010, of course, dabigatran was the only approved direct oral anticoagulant. And then in 2012, rivaroxaban was approved as a direct factor Xa inhibitor, and we see that there was a rapid shift toward rivaroxaban in terms of the number of patients and the proportion of patients that were prescribed rivaroxaban instead of dabigatran. And certainly this may be due to the convenience factor, as particularly for the indication of acute venous thromboembolism, there is a recommended or required 5-day overlap with intravenous heparin for dabigatran. So the convenience of not having to have an IV overlap with rivaroxaban may have led to that shift in prescription practices. We also saw that starting in 2015 and 16, after the FDA approval of apixaban, that there was a shift toward, and in 2016 the plurality of prescriptions were actually for apixaban. And this may be due to literature which had suggested lower rates of bleeding complications with apixaban as compared to the other anticoagulation options. There are certainly some limitations to our study. This was a single center study, and we didn't have a direct comparison to either a control group either on warfarin or no anticoagulation. But there are reasonable estimations and quantitations of the risk of bleeding in those populations within the literature, which we used as a comparison. Further, we do not have significant numbers of patients with either renal or hepatic dysfunction, or in particularly older ages. So in terms of further study, it may be worthwhile to look at these populations specifically to see if the bleeding risk may be higher in those patients, as we know that it may be for those anticoagulated with warfarin. However, overall, we conclude that it is safe to continue direct oral anticoagulant use through the procedure time for arthrocentesis and joint injections, and that these procedures do not need to be delayed in order to hold anticoagulation prior to the procedure. Thank you for watching, and we hope you enjoyed the article.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.